Good afternoon, everybody. My name is Dr. Syed Waqas Bukhari. I'm one of the consultant hematologists at Shaukat Khanum Hospital. Thank you for joining us for this webinar on COVID-19 COVID-19 impact on oncology. We have four excellent speakers on this topic. The first speaker is Dr. Salma Abbas. She's a consultant in infectious diseases and general medicine. She'll be talking about COVID-19 among cancer patients. She'll be followed by Dr. Hassan Sheriar. He's a consultant medical oncologist, and he'll be talking about oncologist perspective on COVID-19 and solid tumors. Third speaker is Dr. Nadeem Siddiqui. She's a consultant medical oncologist, and her topic is guideline endorsed recommendations regarding cancer management in COVID-19 environment. And last but not the least is Dr. Ahmed Awais, who will be joining us from the US, and he'll talk about thrombosis, anticoagulation, and COVID-19. We'll get the ball rolling, and I'll invite Dr. Salma Abbas to come and give her talk.
Thank you, Dr. Waqas. Assalamu alaikum everyone, I'm Salma Abbas. I'm an infectious diseases consultant at Shaukat Khanum Hospital, and the title of my presentation is Coronavirus Disease 2019, also known as COVID-19 among cancer patients. Now here's the outline of my presentation. I will start with a brief background, followed by why it's important to study cancer among COVID-19 infection among cancer patients. I will then discuss clinical characteristics and outcomes of cancer patients with COVID-19, followed by international guidelines for cancer patients, as well as practices at Shaukat Khanum, and then a conclusion. So starting with the background, so COVID-19 is an infection caused by SARS-CoV-2. What started as an outbreak in Wuhan, China in December of 2019 quickly progressed to a pandemic. It's a highly transmissible infection. The disease spectrum varies from asymptomatic infection, mild respiratory tract infection, pneumonia, and goes all the way to ARDS. The high-risk groups for poor outcomes include age greater than 50 years, males, health conditions such as obesity, diabetes, and hypertension, African American race, and immunosuppression. Now coming to the important question as to why it is important to study COVID-19 among cancer patients. So there are many reasons. Number one, patients with cancer may be on immunosuppressive therapy and steroids, which obviously puts them at risk for poorer outcomes. Cancer patients may also be on immunomodulators, due to which they would have an augmented response to infections. They have high levels of contact with healthcare systems. For example, they're coming in for appointments for chemotherapy, radiation, monitoring, supportive care, surgery, so on and so forth. To date, a few studies exist on cancer patients with COVID-19. Most of these are small case series that describe clinical characteristics. There are also case reports on treatment of cancer patients with COVID-19, and recently a large cohort was published. This is the largest study to date that describes clinical characteristics and outcomes among cancer patients with COVID-19, and this is something that will take up the majority of the time that I have for this presentation. So the title of the study is Clinical Impact of COVID-19 patients, COVID-19 on patients with cancer, and this is a cohort study. The data source for this was the COVID-19 and Cancer Consortium. The study population, so they chose 928 patients aged greater than 18 years from USA, Canada, and Spain. And the study period was March 7th to May 7th. The primary endpoint that looked at was all-cause mortality within 30 days of COVID-19 diagnosis. Now looking at the demographics, so if you look at the age of the patients who were enrolled in this study, so about 40% 44% were less than 65 years of age, and about 56% were of ages over 65 years. When you look at the sex, so there was equal distribution. If you look at male and female patients were included in the study. As far as race and ethnicity is concerned, non-Hispanic whites constituted 50% of the population. Hispanic blacks constituted 16% of participants. Hispanics constituted for about 16%, and the race was not known for the rest of the patients. ECOG or performance status was 0 or 1 for 66% of the patients, 2 for 8%, 3 or 4 for 5%, and unknown for 18%. This is important because patients with poor ECOG are not good candidates for chemotherapy, so on and so forth. And if these patients are on chemotherapy, let's say their ECOG is 2, they're started on chemotherapy, and on top of that, if they get COVID-19, they're obviously in for poorer outcomes compared to other patients. Look at the smoking status of these patients. Never smoked, 51% had never smoked, and the other half were either former smokers or current smokers. Obesity, so 19% were obese, and the data was either missing or not specified for the other patients. Look at the number of comorbids. So 14% had no comorbids, 22% had 1, 25% had 2, 13% had 3, and 21% had greater than 4 comorbids. So about 86% had 1 or more comorbids. Now moving on to the details of underlying malignancy and the treatment these patients received. So starting with the types of malignancy, solid tumors were the vast majority of cases in about 82%, and the most common solid tumors were breast, prostate, and gastrointestinal. Hematologic malignancies overall accounted for 22% of the cases included. The most common ones were lymphoid neoplasms, multiple myeloma, low-grade non-Hodgkin lymphoma. Acute lymphocytic and myeloid leukemia accounted for 1% cases each. Look at the cancer status. So 45% had cancer in remission without any evidence of disease. 32% had present evidence of disease, but they were responding to treatment. 11% had present evidence of disease with progressive disease. Now moving on to the types of anti-cancer therapy these patients were receiving. So about 60% had not received any treatment for cancer over the last 4 weeks. Non-toxic therapy was administered to 22% of the patients included in the study over the last 4 weeks. Targeted therapy among 8%, endocrine to 9%, immunotherapy to 4%, radiotherapy to 1%. And now if you look at surgery within the last 4 weeks, so 87% of the patients had no surgery over the last 4 weeks, and 3% had surgery over the last 4 weeks. Cytotoxic systemic therapy was administered to 17% of the patients within the last 4 weeks. Among those were included in the study. Results. So the most common presenting symptoms of COVID-19 among cancer patients included in the study were fever, that was seen in 64% of the patients, cough seen in 61% of the patients, fatigue or malaise, that was seen in 43% of the patients, dyspnea was seen in 41% of the patients, and asymptomatic infection was seen in 4% of the patients included in the study. 466 patients, which comes up to about 50%, required admission. Of these, 175 patients, which is 38%, were actively receiving anti-cancer therapy of some kind. And the 30-day all-cause mortality, the crude number is 121, and the percentage is 13% of this cohort. Now, a total of 121 patients died in this study, as I mentioned earlier. Those admitted to the ICU, a total of 132, and the crude mortality among ICU admissions was 50. Those required mechanical ventilation, so the total number of that was 116, and the crude mortality was 50. Among solid organ tumors, the percentages really have not been very variable. Now, if you look at the cancer type, solid organ tumor, so 12% died, 12% were admitted in the ICU, and 11% required mechanical ventilation. Hematologic malignancies, so 14% died, 22% were admitted in the ICU, and 17% required mechanical ventilation. For cancer status, so those in remission, 9% died, 15% were admitted to the ICU, and 13% required mechanical ventilation. For patients with stable disease and treatment responsive, 14% died, 14% were admitted in the ICU, and 13% required mechanical ventilation. For progressive disease, the percentage of those who died was higher, was 25%, but those admitted to the ICU and those requiring mechanical ventilation is still comparable to other groups. Now, the type of anti-cancer therapy that was administered to them, so those with no cancer therapy over the last 4 weeks, 14% of these people died, 16% were admitted to the ICU, and 14% required mechanical ventilation. For non-cytotoxic therapy, 11% died, 12% were admitted to the ICU, and 12% required mechanical ventilation. And for cytotoxic therapy, 14% died, 11% were admitted to the ICU, and 8% required mechanical ventilation. Important to note that those patients who were on palliative therapy, so a very small percentage of those went to the ICU or required mechanical ventilation, obviously because of their goals of care that were different from those requiring active anti-cancer treatment. So overall, the factors that were found to be associated with mortality and in a way that was statistically significant was increased age. So as age increased by 10 years, the odds ratio, the odds of developing or being associated with higher mortality increased by 0.84. Male sex was associated with higher mortality. Smoking status, so former smokers versus never smoked, the odds of mortality were higher amongst the group that had smoked. Number of comorbidities, 2 versus none, so the ones with 2 or more comorbids had a higher odds of mortality compared to those who did not have comorbids. ECOG of 2 or higher was associated with higher odds of mortality. Active cancer compared to patients in remission was associated with a higher odds of mortality. And interestingly, they also included analysis of the treatment received by these patients. However, there was either hydroxychloroquine in combination with azithromycin, hydroxychloroquine by itself, or azithromycin by itself that was looked at. And they saw that azithro plus hydroxychloroquine was associated with higher mortality. The odds was 2.93 times higher compared to those who were either receiving standard of care or no treatment at all. Interestingly, as you would imagine, or one would think that types of anti-cancer therapy would have an impact or would be associated with poorer outcomes, or prior surgery, as a recent case study suggested, may be a factor associated with higher mortality. However, in this cohort, these findings were not seen. So race and ethnicity, obesity, cancer type of anti-cancer therapy received, and recent surgery were not associated with higher mortality in this study. So this study was a great start, obviously, because it's been hypothesis generating. Overall, they found that there was a 13% mortality associated with cancer. And they also saw that surgery, the types of anti-cancer treatment, etc., are not associated with poorer outcomes in cancer patients. However, this does have limitations. For example, the follow-up period was pretty short. It was 30. They were only looked at 30-day mortality. The study was retrospective in nature, and very importantly, there were regional differences in COVID-19 response, and the regions included, for example, USA, Canada, and Spain, were on different timelines of the pandemic. One had seen a full-blown pandemic, whereas the other areas have started to see their cases. And there was missing data in the study, and of course, the data was derived from large tertiary care centers, and there was underrepresentation of community practices in this study. So what are the future steps as far as what we need to learn about cancer patients with COVID-19? So we do need further studies with larger sample sizes that should be carried out across the globe and not be geographically limited. The studies should have prospective design. We should compare cancer with non-cancer patients so that if we get a high mortality of 13%, let's say, we can compare it to the general population. However, if we have non-cancer patients in the same study, it would give more credence to the results. We should also have studies to compare various types of cancer and their outcomes. The numbers in this study were very low, for example, for hematologic malignancies such as acute leukemias and lymphomas, where patients, I would imagine, would have a much worse outcome compared to solid tumors. And again, clinical management of COVID-19 for cancer patients, this is something that really hasn't been looked at, and barring a few case studies, a few case reports, there's not much data available on cancer patients and treatment of COVID-19 as yet. So coming to the practices at Shaukat Khanum Hospital. So as far as testing of cancer patients is concerned, we are currently testing all symptomatic patients who meet our case definition, which is the presence of fever along with one other symptom such as cough, chills, sore throat, myalgias. In addition, we are also testing a subgroup of asymptomatic patients, those who are either planned for operative procedures or those with acute leukemias and pre-transplant who are planned for chemotherapy. We test these patients 48 hours prior to their procedure or planned chemotherapy. If the test is positive, we defer their treatment for at least 2 weeks, at which point we bring the patient in and reevaluate them to see if the infection has cleared or their symptoms have resolved. If they test negative, then we proceed with the planned procedure or chemotherapy. Our admission criteria at present, so we are only admitting patients who have some evidence of hypoxia with O2 sats of less than 94% on junior. Management currently, so for patients who are non-ICU and are admitted to the floor, it's a combination of supportive care with oxygen, supplemental oxygen as required by the patient, self-proning, we encourage patients to prone themselves. And as far as the medications are concerned, so currently we're only administering montelukast as an anti-inflammatory to these patients. For patients who have shifted to the ICU and have shown evidence of cytokine release syndrome, we are administering steroids, methylprednisolone 0.5 to 1 milligram per kg for 5 to 7 days to these patients. And we are also administering tocilizumab in select cases, obviously, who do not have any contraindications such as neutropenia or other factors after discussion with their oncologist. An additional thing that we are doing at our center is therapeutic anticoagulation for ICU patients with elevated D dimers. This is a controversial topic, but upon review of the literature, we found that patients are at higher risk. These patients with CRS and ICU patients are at higher risk for VTE events. This is a prothrombotic state. Even patients who do not have overt evidence of VTE will have been seen to have microthrombi and so on and so forth on autopsies. So this is the reason, in consultation with our hematologists, that we decided to go ahead and make this a part of our guidelines for ICU patients. At present, we don't have a very large cohort of patients to discuss from Shaukat Khanum at this point, but hopefully if we have further webinars, we can definitely discuss our own data as well. Thank you.
Hello, Assalamu alaikum. This is Dr. Hassan Shahriyar. I'm a medical oncologist at Shaukat Khanum. I will be talking about an oncologist perspective on COVID-19 infection and its impact on solid tumors, with a special emphasis on the thoracic cancers. So this is the outline of my talk. I believe my previous presenter discuss some of the data that I will also be discussing here. But basically, I will be talking about the two large data sets that have evaluated quite extensively the impact of COVID-19 infection on cancer patients. So the first largest data set comes from this COVID-19 and Cancer Consortium, or CCC-19. And the second biggest data set is the Thoracic Cancer International COVID-19 Collaboration, or TERAVOLT. And then I will delve into the epidemiology and case fatality rate of these two data sets. We'll discuss some of the factors which were associated with the increased mortality, and also compare the two populations in these data sets. And then moving on, I will also briefly go over some of the case fatality rates seen in cancer patients from the hardest hit areas in the world, such as New York, Italy, and France. We'll quickly review the vulnerability of patients with thoracic malignancies, and then we'll also discuss some of the strengths and limitations of these data sets, and finally we'll reach some conclusions. So COVID-19 infection affects everybody or has the potential to affect everyone across the general population. So why are we so concerned about the impact of this infection in cancer patients? So there are at least 5 physiological and systematic reasons why cancer patients represent a special cohort which is at increased risk of adverse outcomes with this infection. Principally, the advanced age, as we know that cancer is more prevalent in higher age groups. Also, the presence of coexisting comorbidities that we see in cancer patients, such as diabetes, heart disease, chronic kidney disease, and chronic liver disease. And also, the frequent contact of cancer patients with the healthcare system, not just in terms of their frequent visits for infusions, but also those who are on surveillance who need to come for their outpatient visits. Cancer patients also have a decreased immunity, which is either a direct effect of their cancer or could be related to their treatments. Also, some of the supportive care measures, such as use of steroids for anti-emesis and pain control, could also result in decreased immunity for these patients. And finally, cancer patients generally have a lower performance status compared to the general population. So, as this was discussed quite in detail in the last presentation, the COVID-19 and Cancer Consortium is one of the largest data sets or registries which have enrolled cancer patients across over 100 institutions in North America. And they give us a quite detailed information about the impact of COVID infection in this population. So the mission statement for this registry is to collect and disseminate prospective, granular, uniformly organized information on people with cancer who are diagnosed with COVID-19, and to do that at a scale and as rapidly as possible. I should also note that the update of this registry was presented just a few days ago at the annual ASCO 2020 meeting in a special session on COVID-19. For this particular registry, the methodology included all those patients who were PCR confirmed for SARS-CoV infection. They were included. They accrued cases during the first 30 days of the registry, and they evaluated their outcomes. The primary outcome was a 30-day all-cause mortality, and the secondary outcomes included oxygen requirement, rate of hospitalization, rate of ICU admission, the rate of mechanical ventilation, and a composite of severe illness. The second largest registry for patients with cancer, and particularly thoracic malignancies, is known as TERAVOLT, and this is also like CCC-19, a collaboration of over 200 cancer centers across the globe in 4 continents. Similarly, they also are evaluating the effects or gathering information on the demographic factors, comorbidities, cancer characteristics, and therapies that are risk factors for hospitalization and mortality. They also aim to understand the clinical course of patients with thoracic malignancies which are infected by SARS-CoV-2, and importantly, to evaluate the long-term impact of cancer outcome related to the care adjustments and delays in patients with thoracic malignancies. Their methodology is slightly different, although it includes any patient with thoracic cancer who is diagnosed with COVID-19 infection, either using a RT-PCR based methodology, or also on clinical grounds of suspicion, such as clinical symptoms of upper respiratory tract infection, which are consistent with the case definition of COVID-19 infection, or radiographic features of COVID pneumonia. So let's look at the patient population in these two large registries. Cancer Care Consortium has accrued around 928 patients with any cancer type. The most commonest cancer type is breast cancer, which constitutes about 21%, followed by prostate cancer of 16%. GI malignancies are around 12%, hematological malignancies around 11%, and thoracic malignancies were about 10% of this cohort. These are all confirmed cases of SARS-CoV-2 by RT-PCR. The TERAVOLT registry, as indicated earlier, is consisting of thoracic cancer patients, either primary lung malignancy or metastases to the lungs. And they have accrued about 400 patients as of May 8th. And these were also cases confirmed with SARS-CoV-2 by RT-PCR or clinically suspected or radiographically suspected. And this data set was also presented at the ASCO 2020 meeting in the special session on COVID-19 infection. Looking at the mortality rate that was seen in the Cancer Consortium, with a median follow-up of 21 days, about 121 patients, or 13% of the cohort, had died. Patients who required mechanical ventilation were about 12%. Patients who were admitted to the ICU were about 14%, and a rate of hospitalization was noted in about half of this population. The composite outcome, which included elements of severe illness, was seen in about 26% of the population, or 1 in 4 patients required. 1 in 4 patients had a serious illness as a result of COVID-19 infection. In the subgroup analyses, I think pertinent findings are that there is a prevalence of slight higher prevalence of male gender, about 17%. Patients above the age of 75 were about 25%. Patients who had active cancer or cancer in progression were also in the range of 25%. Patients who had a poor performance status and required intubation were about 85%. The mortality rate in the TERAVOLT registry was as follows. With a median follow-up of 33 days, about 141 patients had died, which is about 35.5% of the population. The deaths attributed directly to COVID infection were about 80%, and cancer-related deaths were about 11%, although the distinction can be difficult in some of these cases. Patients who required hospital admission were about 78%, 8% required ICU admission, and 5% required mechanical ventilation. Median length of hospitalization was around 10 days. Looking at, in a different way, patients who recovered versus those who died, patients with a higher age, with an average of 70, were more common in the patients who died as opposed to those who recovered. Male gender, again, more deaths in male gender. With regard to the smoking status, patients who were former smokers or previous history of smoking had a higher incidence of mortality compared to those who were never smokers. And similarly, patients with a poor performance, ECOG performance status had higher mortality compared to those who had recovered. Now, looking side by side, the morbidity and mortality in these two registries, again, as we noted earlier, the population size is about 928 patients in the Cancer Consortium and 400 patients in the TERAVOLT registry. Mortality rate 13% in the Cancer Care Consortium and 35% in the TERAVOLT. ICU admission was also higher. It was higher in the Cancer Consortium as opposed to the TERAVOLT, and similarly, mechanical ventilation was higher in the Cancer Consortium group as opposed to the TERAVOLT. These are interesting findings in the sense that there is a higher mortality seen in the TERAVOLT registry, yet there is a lower rate of ICU admission and mechanical ventilation compared to the Cancer Care Consortium group. And I'll discuss some of the factors that might be responsible for this apparent disparity. Hospitalizations were significant in both groups. Some of the factors which were independently seen associated with mortality were, number one, age. There was a higher odds ratio, hazard ratio of dying in both the groups for patients who were older versus younger. Patients with a poor ECOG performance status had a 3 to 4-fold higher hazard ratio of dying. Patients who were on active cancer, patients who were on chemotherapy versus those who did not have active cancer or so-called stable disease, or those who were not on chemotherapy. Patients with active cancer and on chemotherapy had a 5-fold higher chance of having a poor outcome compared to those who were not. And in terms of comorbidities, there was also significance noted in the univariate analysis in both groups. So among the many risk factors which have been associated with higher mortality, these scores have been independently verified as underlying risk factors for adverse outcome. Differences. So in these two registries, we saw that patients who were former smokers had a higher chance of adverse outcome consortium group, but not seen in the TERAVOLT registry. Similarly, the male versus female disparity seen in the Cancer Care Consortium was not seen in the TERAVOLT registry. Use of steroids was more associated with an adverse outcome in the Cancer Care Consortium group compared to the TERAVOLT group. And in terms of cancer stage, there were 45% of patients in remission or no evidence of disease in the Cancer Care Consortium registry, as opposed to 60 to 76% of patients with stage 4 or active cancer in the TERAVOLT registry. Also importantly, I think the region of these registries do matter. Cancer Care Consortium, as we noted, is predominantly a North American registry, whereas TERAVOLT is mostly European with a large contribution from Italian population. If you look at the time of accrual into these registries, I think that's important, and that can be used to explain some of the higher mortality we saw in the TERAVOLT registry. So the TERAVOLT registry started accruing patients from March 26th till April 12th. And if you look at the time frame when these regions underwent a lockdown, that preceded the accrual of these patients. So in Italy, Lombardy area, lockdown started in February 22nd. And this basically means that these patients in the TERAVOLT registry were accrued during a time of healthcare surge when the hospitals were over capacity and probably ability to have mechanical ventilation or ICU admission was restricted due to healthcare surge. Whereas in the Cancer Care Consortium group, the accrual time frame is around or after, sorry, it's before the healthcare surge took place. So the lockdown in different areas took place in different time frame, from California in March 19 till to April 2nd in Tennessee, while the patients are already enrolled, and these patients were enrolled therefore at a time when the healthcare capacity was not surged. So the national and local government response to the COVID-19 pandemic took place during the outbreak, and during this time, the facility planning and national directives for the ICU implementation were also instituted during this outbreak. If you look at the critical care bed per capita in the two different registries, Cancer Care Consortium, which is predominantly a North American registry, you see 34.7 beds per 100,000 inhabitants. And it varies it's quite variable in the TERAVOLT registry, ranging from 29.2 beds to 6.6 beds per 100,000 inhabitants in the UK. There was no uniform criteria for ICU admission. It was believed that if you guarantee intensive treatment to these patients, they will have a greater chance of therapeutic success. And the criteria for ICU admission is still being looked at as we have more data coming out from the experience of treating these patients. Now, quickly looking at some of the other hard-hit areas around the world and the impact of COVID infection on cancer patients. If you look at China, in which the cancer patients are shown here in orange bars, there is a uniformity across the board in terms of death, ICU stay, severe critical illness, and need for invasive ventilation in cancer patients, far more than patients without cancer. And similarly, in terms of timeline of their severity, cancer patients did worse than the patients who did not have cancer. From New York, again, cancer patients demonstrated a markedly increased COVID-19 mortality rate compared to non-cancer patients in all New York City COVID-19 patients. The mortality rate was significantly higher, 25% versus 14%. And in subgroups, which is, there's a lot of bias in these analyses, but the observed mortality was about 55% among thoracic malignancies, 14% in breast cancer patients, about 15% in genitourinary, and 38% for GI cancer patients. From Milan, case fatality rates in cancer patients with COVID-19 infection was 19% for the elderly with the age cutoff of 75 years or more, and the overall mortality rate in cancer patients was about 8%. This is the data from Institute Curie from Paris, France. They had in their registry about 141 patients. 77% of them were PCR confirmed. These predominantly consisted of breast cancer, hematological malignancies, and thoracic malignancies. About 3/4 of them had advanced disease, and about 60% of these patients had received multiple lines of treatments with a palliative intent. The ICU admission rate was about 8%, and the overall mortality rate was about 18%. In the multivariate analysis, baseline oxygen partial pressures of less than 96% were associated with a significantly higher odds ratio of mortality, and also extent of radiographical signs of lung disease also had a higher odds ratio of adverse outcome. And this data was also presented at the ASCO 2020 annual meeting by Dr. Giuseppe Corigliano. So are patients with thoracic cancer more vulnerable? So the data does suggest that these patients are more vulnerable. There's both pathophysiological rationale. These patients have a decreased lung function, and some of the pathophysiology of COVID-19 infection involves microthrombi in the lung vasculature, as well as coagulopathy. All of these affect lungs and has a higher mortality associated with it. If you look at the data in terms of patients with no cancer or other cancers without lung metastases, there's a clear separation of the curves compared to patients with lung cancer or other cancers with lung metastases in terms of their severe events over time. And they also had higher chance of death, ICU stay, and invasive ventilation. Limitations. So the COVID-19 case definition in TERAVOLT trial was somewhat different than what we saw in the Cancer Care Consortium group. They included patients based on the clinical suspicion and radiographic findings. In European centers, the pandemic scenario resulted in a very difficult triage decisions, which affected the TERAVOLT population and could have resulted in higher mortality, as we discussed in the healthcare surge time frame of accrual of these patients. Patient selection of stage 4 in non-small cell lung cancer. There was about 70% of patients with stage 4 lung cancer in TERAVOLT. So it's selecting a very high risk group. There was a high proportion of patients in remission in the Cancer Care Consortium. So about 45% of patients were in remission. So that could have affected or skewed the curve towards a slightly better outcome. Also, there was no clear data collected on the prevalence of DVT or PE in both of these registries. There was no clear definition of eligibility to ICU in these patients as well. Now, these are cross-sectional studies, so the data is collected retrospectively and prospectively, and there is no real-time data capture. There was no auditing. There's no standardized outcome definition. The case registry forms also had limitations in terms of their data collection, and I believe this is largely due to the effort that was started on a very urgent basis, and the idea was to capture as much information as possible rather than have a more refined data collection. So there are multiple biases in these data sets, and these include selection bias, recall bias. There's confounding by indication, by changes in practice or disease evolution. Some of the sophisticated methods of statistics were also not applied thus far. So there's no propensity score adjustments. Controls with non-cancer patients are not available. Stratification for stage and lines of previous therapies and other covariate adjustments are not done in these data sets. So all of these could now lead to serious confounding and remain due to the impact of unmeasured confounders and unmeasured risks on treatment decisions. The strengths of these registries, so these are the largest real-world data sets which are investigating risks for hospitalization and death in cancer patients. This was an unprecedented global effort to collect data of patients with cancer affected by COVID-19 in a very short span of time. In both studies, independent factors associated with increased mortality after adjustment were older age, number of comorbidities, ECOG performance status of 2 or more, active cancer, and chemotherapy alone or in combination. These data sets also ask of some open-ended questions, and one of the important one is how does the severity of the pandemic as defined by the R0 value affect the cancer care prioritization and cancer intensity optimization in these groups. So what it means is that during a time of severe pandemic peak, how would your cancer care priorities and treatment intensity will change as opposed to when the epidemic is close to normal or close to normal time in the normal intensity range. I think the guidelines are still being looked at in terms of their outcomes, and we don't have enough data yet to give a very clear and concise recommendation on that. Should cancer patients be prioritized for the ICU triage or admission based on disease stage and specific evaluation? I think it's a very important, pertinent question as we attempt to optimize and ration our healthcare resources in resource-constrained settings. But again, more data is required before we can make informed, educated decisions regarding triage of these patients to the ICU and hospital. How would you ensure that all patients with cancer get triaged fairly? Again, as we discussed, we need more data, and some of these data coming from these registry needs to be prospectively validated. And also an interesting question on the type of cancer treatment, especially immunotherapy. Does it have any protective role in preventing or overcoming SARS-CoV-2 infection? Immunotherapy, as we know, has an effect on T cells, which leads to strengthening of the immune response. However, if that plays any role in overcoming or fighting the infection is not known, and there is some data from China in lung cancer patients who were treated with immunotherapy that might have showed benefit, but the data, the quality of data is poor, and no definitive conclusions can be drawn at this time. So my conclusions: older age, number of comorbidities, ECOG performance status of 2 or more, active cancer, and chemotherapy alone or in combination increase the risk of mortality in cancer patients with COVID-19 infection. We not only just need preparedness and facility planning for suspected COVID cases, but also we need preparedness and planning for the treatment of cancer patients in these scenarios. Cancer treatment prioritization should balance interventions based on the magnitude of benefit and the clinical setting. And in this regard, the guidelines issued by different societies such as ASCO and ESMO can help play an important role. One last slide that I added in the end, I felt that it was important to also highlight some of the research issues associated with cancer patients during COVID-19 times. One of the important questions is to understand the utility of PCR testing. Should we be testing all patients with PCR, with cancer, with RT-PCR, or should we only restrict it to the symptomatic patients? We need longitudinal serological studies urgently to determine the extent and duration of immunity to SARS-CoV-2 infection, so we can plan our treatments later on accordingly. We need to develop an epidemiological model to estimate the cumulative incidence of COVID-19 within a specific time frame in a pandemic scenario. So better modeling is required to preemptively design treatments and provide optimal care to these cancer patients. We need to identify viral, environmental, and immunological factors that, in combination will determine the dynamics of SARS-CoV-2 infection. We need to determine the COVID-19 morbidity and mortality according to the treatment type. So chemotherapy, targeted therapy, immune checkpoint blockade, or immunotherapy. How do they individually affect cancer patients who are exposed to the COVID-19 infection? With that, I'd like to end my presentation. Thank you for listening.
मुझे टाइम को बता देना कुछ हाँ 15 मिनट से पहले मुझे बता देना मैं फिर अपनी कट कर सकती हूँ नहीं तो मुझे फुल स्क्रीन करें Okay, so Assalamu alaikum everyone. So I thought we'll just look at COVID-19 related issues that we're facing as medical oncologists, and I'm sure that all of us are making modifications, but it's also nice to know what is happening internationally and what are the experts saying about it. So essentially, our whole goal remains that we want to minimize patient interaction with healthcare centers, and we want to look after patient safety. At the same time, we want to conserve the resources and provide effective care. So what we need to do is, whenever we have a patient in front of us, our aim is to have a balanced approach, because both are important. If we delay cancer care or if we don't give optimum care, our concern is that delaying therapy can create a lot of problems and disease can progress, as well as, but at the same time, at the moment we are fighting COVID-19, which has significant morbidity as well as mortality. So we should, most authorities recommend that we should risk categorize when we are planning therapy, and that should be according to the tumor type, according to the comorbidities and age, of course, as well as whether the therapy that we are giving is curative or palliative. So, for example, if and so my guidelines are, I've taken from NHS, from US, from NCCN, US alliance groups. So it's sort of an overall consensus about this, that if we have a tumor which is rapidly progressing and without therapy, it can have devastating effects, then we should delay therapies in the patients who are less than 70 years old. However, despite being a high-risk disease, in older individuals, we have to think of the benefits of immediate therapy versus the risk because of the pandemic. Then those tumors which are intermediate risk of regression, in those we could delay, and the consensus is that within 3 months, if they are able to give therapy, that should be acceptable. And particularly for individuals who are 50 years and older, so age plays a very important role. Then we come to the tumors which are low risk. In those cases, it's safe to delay for more than 3 months. For example, if we have low-grade lymphomas or non-melanoma skin cancers, even patients with breast cancer who are like early stage ER positive, then we may just start the patient on neoadjuvant endocrine therapy. So we will just look at the high risk group. Obviously, I'll not be able to cover all the tumors because of we have limited time, but we'll just focus on the high risk in which we have to start therapy. So therapy-wise, as you heard the previous speakers, mostly elective surgery is postponed, but those patients who present with lung mass suspicious of malignancy or ovarian CT scan suggests ovarian malignancy, or pancreatic mass which is suspicious of malignancy, liver mass, for them we need to go for surgery upfront, as well as for cervical cancer stage 1B endometrial type 2, which tends to be aggressive and spreads quite rapidly, and in urothelial, those which are non-muscle invasive with high risk as well as muscle invasive surgery should be offered, and kidney cancer if it is localized, sarcoma which is non-low grade. So coming to chemotherapy, as you heard previously as well, we've already had a hematology webinar, but just we know that all patients with hematological malignancies which are acute, rapidly progressing like acute leukemias, high-grade lymphomas, so the myelomas which need therapy, we need to start as per the Julian guidelines, but we can make some modifications. Germ cell tumors metastatic, we cannot wait because these tumors progress rapidly and have a high mortality if left untreated. So non-low grade sarcomas, rectal cancer is also considered as a high risk for progressive disease. Small cell lung cancer, we know that it's aggressive and it really behaves like an acute leukemia, so these patients need to start chemotherapy, and most head and neck cancers also require chemotherapy. So once we made a decision that the patient needs to have chemotherapy and we can't really delay, then we need to decide how can we make modification and according to the COVID-19 pandemic. So we should aim to use therapies which are effective but less immunosuppressive than chemotherapy. And some type of therapies can be given at home, endocrine therapies, target tyrosine kinase inhibitors which can be given. So oral therapies like capecitabine, oral etoposide, one could give depending on the malignancy, as well as like switching from IV targeted, like we have Herceptin, trastuzumab. You can switch it to subcutaneous, and subcutaneous there are studies to show, and we actually have done that for some of our patients, that once they are trained they can do it at home. And then also we want that if at all we are going to give chemotherapy, we need to make sure that the patient gets therapy where there's the least possible exposure to COVID-19. So it should be in an area where the COVID-19 patients are not close by, and we have to look at our resources and feasibility. Then when we give chemotherapy, there are some problems which we face with most of the chemotherapy drugs, which are general. Coming to neutropenia, so it is suggested, as you all know, that mostly patients on chemotherapy, if there's a risk of febrile neutropenia more than 20%, then to give the prophylactic GCSF. However, in these days, my recommendations are that if the risk is more than 10%, then we should give them prophylactic GCSF. And that will prevent neutropenic fever, that will prevent infections, and the overwhelming numbers of patients coming to the ER, those numbers will go down. But one caution that I wanted to highlight was that if a patient during these days presents with respiratory infection or symptoms, or is confirmed or is a suspected case of COVID-19, then it's better to avoid GCSF, because GCSF can cause pulmonary inflammation and inflammatory cytokine release, as well as capillary leak, and actually can have an adverse effect on the outcome. So we need to keep that in mind. Second is anemia. Anemia we see frequently, and these days there's shortage of blood products, and we don't have donors and several other factors. So it is recommended that erythropoietin use should be broadened these days for solid tumors, and there are studies to show that if we add IV iron, then the results are better. So we could do that, and I was thinking that if we don't want to give parenteral iron, maybe we give like oral works quite well actually. So we could do that, and we can coincide the timing of administration of erythropoietin and iron with blood draws or visits. Then also we need to use the lowest possible dose of erythropoietin, because the caution in this case is that there's an increased risk of thrombosis. So we don't want to give the standard doses. So the lowest possible dose, which will increase the HB, and once the HB is around 10 grams, then we should hold for the erythropoietin. Thrombocytopenia, generally the threshold for transfusion is we usually have for the floor less than 10K, and chemo bay is around 20. So we could, like we are trying to keep the threshold of platelet count even lower, maybe around 6. But still, if still there are no platelets available, and or maybe a patient is bleeding, then we could use tranexamic acid. However, we must keep in mind that this contraindication of tranexamic acid is that it can cause thromboembolic phenomena. So any patient who has embolic stroke or DVT or urinary tract bleeding, in those cases we should not be using these antifibrinolytic drugs. And also, if the platelet count comes up to 30K, then we should hold it. So we shouldn't just continue blindly in these patients. Another is thrombopoietin like drugs like romiflostin. This is, I mean, in the next slide you'll see there are quite a lot of therapies which are expensive, but I thought it's still mentioning that you need to know that you might have some patients where you can use it, and then it's like you can give it in solid tumors if platelet count is less than 30, and then once the count comes up to 75, then you can like hold it. Again, this also has a risk of thrombosis, so we should keep that in mind. So those were the general guidelines. Next we come to the tumor type, because obviously we have to decide according to the risk category and the type. You've heard quite a lot of about lung cancer from the previous speaker. So just generally, just brief recommendations of what others are doing is that in squamous or non-squamous cell lung cancer, you could give single agent pembrolizumab, and the other is that if you're giving maintenance in non-small cell, maintenance pemetrexed and pembrolizumab, because you want to avoid chemotherapy and you want to avoid visits to the hospital or chemo bay, then it's better to stop pemetrexed, and you could give pembrolizumab to reduce the toxicity. Those patients who had chemoradiotherapy and you have to start chemotherapy, there are several combinations of doublets, but what is suggested is that I would suggest, and there is some evidence that carboplatin paclitaxel, because it's straight, it's 3 weeks, every 3 weeks, instead of using protocols like gemcitabine carboplatin, because the patient has to come to the chemo day weekly, or cisplatin bendamustine. So carboplatin. And then for adenocarcinoma, osimertinib as first-line therapy. Actually, from this ASCO only today, one of the highlights of 2020 ASCO is that osimertinib has shown a huge survival benefit. So I think because of the time is running short, lung cancer, stage 4, instead of going up to 6 cycles, small cell, you can just stop after 4 cycles. Colorectal cancer is important because it's common, and chemotherapy, adjuvant chemotherapy, has a significant curative impact. So if it is stage 3, definitely you need to proceed. but we can make modifications. I'll show you in the next slide. And in stage 2 only if it is, you have to justify to give chemotherapy. Metastatic setting, it is palliative, so we can, if the patients really need it, then you can give it, but you can make significant changes. And because we want to reduce myelosuppression, so this is the US Oncology Colorectal Alliance group, which has recommended that 5-FU bolus has little benefit. So if you're using protocols in which there's bolus 5-FU, you could drop that, and when you drop 5-FU, you could drop leucovorin as well, because so that way the toxicity will be less. The other one is that IV 5-FU capecitabine is equally good, or maybe even better. So IV regimens can be switched to capecitabine, and then you can simplify or modify the schedule of capecitabine, that you could give continuous dosing of 2 plus 2, 1000 milligram per meter, 1000 milligram BID or 1500 milligram BID Monday to Friday, or you could give 7 days on or 7 days off. So capecitabine is a very useful drug. Otherwise also, but these days I think it is, could be utilized much more. Then other modification ideas are that those patients who have high-risk disease and you're wanting to start adjuvant chemotherapy, and recommendation is doublet. However, you could justify, for example, nowadays if we think that it's the peak of COVID-19, then maybe we can just start with oral capecitabine, give 1 or 2 cycles, and then later on when things are settling down, we could add oxaliplatin, because the benefit of oxaliplatin in this setting is quite small. It's really the capecitabine which will do the job. Then, but delaying is not recommended, because there is sufficient data to suggest that in these patients, adjuvant chemotherapy for colorectal, delaying does affect the survival outcome. So I think that will not be a good idea. And then for maintenance therapy, just single agent capecitabine with or without bevacizumab, depending on like the age of the patient, and again, main benefit is from capecitabine, and we could maybe give some treatment holidays, and or maybe just give oral therapy till the surgery is planned. So you break the therapy. Then the other one is the use of intermittent chemotherapy in cetuximab. This is from the UK guidelines. And for metastatic colorectal with high level MSI, so this is also in 2020 ASCO, that there's significant survival benefit with pembrolizumab. So pembro or nivolumab can be used. For gestational trophoblastic disease, pembrolizumab could be used first line instead of chemotherapy. So you could change the sequence, you can decrease the number of admissions, and also that way by avoiding chemotherapy, you could reduce the incidence of neutropenia. Head and neck, again, pembrolizumab as first line immunotherapy may be used. Hodgkin lymphoma. Hodgkin's is like for relapse Hodgkin, we usually use salvage chemotherapy and go to autologous stem cell transplant. So it is, the consensus is that if we're able to afford, which we can't, but brentuximab is a good drug, so that can be introduced earlier. And those patients who've had brentuximab and relapsed, and nivolumab is showing really good results in Hodgkin lymphoma. So if I have the money, I would use that instead of salvage chemotherapy. But if we are stuck with chemotherapy, then we should have a protocol which is for the chemo bay, and that is you could use cis-gem, because that is every 3 weeks. No, but with gemcitabine you have to give weekly. So, or you could use GVD. So these protocols can be used in the chemo bay rather than in the inpatients. For follicular lymphoma, those patients who are on lenalidomide and rituximab, len is oral, and you can switch the IV rituximab to subcutaneous. So again, that shortens the time. And if the patient, like if patient can be taught or one of their attendants, they could possibly get it at home. The subcutaneous, the whole therapy can be given at home. It is recommended that for maintenance, for follicular lymphoma, maintenance rituximab and obinutuzumab should be suspended for the moment. And for mantle cell lymphoma, we have oral ibrutinib, so that may be used if you have to treat the patients. Myeloma, again, Lendex, oral therapy can be used, or like in second line therapy, again, those patients who have not had bevacizumab, they could have Lendex as second line. For ovarian cancer, first relapse, generally we used to give chemotherapy or chemotherapy plus maintenance PARP. So those patients who are BRCA positive, again, this is like new. So there are 4 new studies which are like I've tried to incorporate, and this is at ESCO again, that there's a very significant benefit of maintenance PARP inhibitors for ovarian cancer. So if we have the drug, we should offer to the patients. Just briefly, melanoma against BRAF positive, then oral immunotherapy, and or combination is meant to be avoided because it's more toxic and can have more visits to the hospital. If you have to switch to IV, then nivolumab or pembrolizumab may be given. Bladder, again, recent most 2020 data, avelumab has shown significant survival benefit in bladder cancer. So you could use atezolizumab or avelumab. For us, yes, most of us will not be able to get this, but it's nice to know the recent most updates, and every now and then you might have some patient that you may be able to give. Just like this is neuroendocrine tumors, 5-FU streptozotocin is IV, so that's also like old therapy. So you could give oral temozolomide and capecitabine, and that way the patient will stay at home. Breast cancer, I'm not going to talk about it today because next week, inshallah, on Tuesday or Wednesday, we are going to do a whole webinar on breast cancer, so we'll touch on that. So just now we were asked this question, so this is a question that we get asked frequently. What do we do with patients who are like COVID? What about the testing in patients who are symptomatic cancer patients? Those patients are going to start therapy. Some centers are doing for all patients. Some are doing for immunosuppressive therapies, which are more like MVAC for bladder cancer, cis-etoposide, but not if you're giving single agent like gemcitabine, docetaxel, because we don't expect them to get really sick and neutropenic. For before autologous stem cell transplant, COVID test, we are doing high dose steroids if we're giving. It is recommended. And so what happens if you have a patient and you are giving chemotherapy and the test comes out to be positive, then recommendations are that you hold the immunosuppressive therapy for at least 14 days from onset of symptoms, and once the symptoms have resolved for 72 hours, you check the COVID test again, RT-PCR, and then there are different recommendations that I found. Some said that you have to wait like 72 hours apart, or you could repeat it in 24 hours. Actually, I'm just coming from the clinic, and one of my patients was new to me, ovarian cancer. She told us that last week she was positive for COVID, and she's having the RT-PCR done, and once it's negative, then you can resume therapy. Just lastly, which therapies can be continued in a patient who is positive for COVID? There is evidence to suggest that ibrutinib may be continued. Osimertinib, there are some 1 or 2 case reports from China. They continue high dose steroids if a patient is on for cord compression and brain mets. Then you just continue. Otherwise, reduce dose. Testicular cancer, yes, germ cell tumor, even with COVID positive, is thought that they should continue with testicular. So essentially, quickly given you quite a lot of tumors updates, and like in some ways we've got experience of others, but now that we are seeing more patients, maybe we can incorporate some of these therapies in our clinical practice, and that will hopefully improve our patients' outcome. Thank you.
Okay. Assalamu alaikum, everyone. Thanks for having me. So the topic that I'll be discussing over the next 15 minutes is thrombosis and anticoagulation in COVID-19 patients. Jim. Okay. Assalamu alaikum. I'm not sure the kidney presentation through here, so I'm just repeating it again. The topic being discussed today is thrombosis and the need for anticoagulation in COVID-19 patients. So this is a pandemic that hit us back in 2019. It was not until mid-February 2020 that there were some reports, with the initial reports coming out in the Journal of Thrombosis and Hemostasis, regarding the high prevalence of thromboembolic events in patients who were basically developing severe pneumonia because of COVID-19. So initially this was reported in the Journal of Thrombosis and Hemostasis. And then as the pandemic spread all over the world, this started to be noticed pretty much everywhere the pandemic was hitting. In April 2020, for example, there was a study out of the Netherlands which showed that out of 184 ICU patients with COVID-19 pneumonia, almost a third of them had thrombotic complications. And this was obviously considered to be a remarkably high percentage in those patients. Now, just, something to keep in mind is that this is not something that is surprising, because even, back about a decade ago when we were hit with SARS and then with the Middle Eastern respiratory virus, there were definitely a high number of cases of thromboembolic events in those patients. So this is really in line with previous, acute respiratory infections. And now in the US, we're also seeing a lot of thrombotic complications all over the country, actually. The only caveat is that, there's a lot of variation in institutional protocols when it comes to using anticoagulation in a prophylactic setting. So really, you have to look at the data individually and see, what percentage of patients actually developed it while they were on or off prophylactic anticoagulation. So the data is highly variable, with different patient populations all over the world. And then finally, the general rule is that the more severe the infection, the higher the chance that the patient will be developing thromboembolic complications. So, this is the data from Colorado here in USA. And this is just to kind of compare the state to the rest of the world. Everybody's been talking about flattening the curve. So this is kind of where things picked up initially in the early part of March, and then things kind of flattened out over the next couple of months. We've been seeing an average of about anywhere from 300 to 500 cases every day for the last 3 months or so. And we're about 25,000 cases roughly. This slide is a week old, I apologize, but this presentation was intended for last week. But essentially, we have about 25,000 patients with about 1,500 deaths to date, with an average mortality rate of about 5% overall. And this is just Banner Health over the 6 states that we cover. So as again, showing the data here, the average mortality about 5 to 6% in the counties where we are at. Again, there's a lot of variation depending on the age. In the 80s and 70s, the mortality rate is as high as 30 to 40%, but in the young folks, it's anywhere from 0.5 to 2%, depending on what age group you look at. So, why do patients develop blood clots with COVID-19? And, we've always heard about the workhouse triad. Pretty much, all the 3 entities that constitute the workhouse triad are active in COVID-19 patients, interestingly, and that's why they're so thrombogenic. So, for example, endothelial injury, there is definitely evidence that there is direct invasion of the endothelial cells by, SARS coronavirus 2, and that's why you see some patients coming in with myocarditis and, this Kawasaki's disease they're describing in children now. So there's definitely some level of endothelial invasion. And then, of course, we know that these patients, who are sick with COVID-19 are often in the ICU, intubated, with release of cytokines and septic shock. So that in itself is a high risk, and they have these devices, the catheters and all that. So secondly, stasis. Again, these patients are obviously in the ICU, often in prone position on ventilators, so they're actually high risk for stasis. And then finally, they are hypercoagulable because the COVID-19 in itself causes, increase in the thrombogenicity of the blood, which includes, the reasons that are postulated and somewhat proven also based on labs include significantly elevated levels of factor VIII and fibrinogen. And just to put this in perspective, usually, we run about 2 to 4 grams of fibrinogen per liter of blood, but in these patients, we've actually seen up to 10 to 15 liters of fibrinogen per liter of blood. So it's a very high level of fibrinogen, which makes it thrombogenic. And then, of course, there's this hypothesis that there are circulating prothrombotic microparticles that could contribute, and then some evidence that hyperviscosity could also be contributing to this. There are also the finding of antiphospholipid antibodies in these patients, but that is thought to be a transient finding. So we can't really prove that as an association, but that's just one of those things that is still being studied as to whether those antiphospholipid antibodies actually contribute to the thrombogenicity in these patients. So, the predominant abnormality is the predisposition to a hypercoagulable state, which is now being termed as thromboinflammation or COVID-19 associated coagulopathy. And just to give you an idea, one of the initial studies that was done, they looked at a series of 24 selected patients who had severe pneumonia in the ICU. And the most commonly found parameters, and this obviously extrapolates to other studies also, was a prolongation of the PTT and PTT, but very slight as opposed to DIC, where you expect to see a higher degree of prolongation. Platelets counts, interestingly, were normal or actually increased in patients. and they think that's likely due to thrombopoietin release. Fibrinogen was increased significantly. You can see in the mean value was about 680 milligrams, about 6 grams per liter. And then the D-dimer also was increased. And the D-dimer is very important because this is actually a lab that is being used in most places to actually stratify patients into low risk and high risk and decide whether these patients need to be put on low dose, full dose, or intermediate dose of anticoagulation. So we use the D-dimer very regularly here in the ICU. And then there are other assays, more so for academic purposes, but definitely these are reasons to promote hypercoagulability in these patients. Again, high factor VIII levels, increase in von Willebrand factor antigen caused by endothelial damage, and then decrease in the natural anticoagulants that are available in the blood, including antithrombin and protein S. Not so much protein C. Just a quick thing on how to distinguish this from DIC. This is very important because a lot of patients in the ICU can go into DIC, and sometimes it becomes difficult because they can coexist. But just a general idea is that in COVID-19 induced thrombosis, you will see just the thrombosis. You will hardly ever see bleeding. I mean, we saw one case of bleeding, and that was somebody who had an intracranial bleed because of a tumor. But other than that, COVID-19 will almost never cause bleeding. On the other hand, DIC, you will see bleeding a lot. Similarly, in COVID-19, the typical findings include a high fibrinogen. So if you see a low fibrinogen, you can think of excluding DIC, COVID coagulopathy, unless it coexists with DIC. Similarly, the hypercoagulable state in COVID-19 is more similar to compensated DIC rather than acute DIC. So like I mentioned, platelet count often normal or elevated, and PTT either slightly abnormal or normal is what you will find in most patients. But again, the thing to remember here is that the principles of treating it are very similar to the principles of treating DIC, which is you don't treat the number, you have to look at the overall clinical picture and then act on that. As far as the clinical features go, again, you will see VTE of all sorts, including DVT and pulmonary embolism. It's very common in COVID-19 patients. How much it leads to mortality is a little difficult. We are still early on. Remember, this is, these things are dynamic. Lots has changed in terms of anticoagulation guidelines, and it continues to evolve. But our goal is to try to minimize any mortality secondary to DVT or PE in these patients. Just, an idea of the seriousness of this. Again, this is not from our hospital because we don't have that kind of volume here, but a series of 150 patients who were in the ICU, they reported up to 43% incidence of VTE. And this included patients who had clotting of extracorporeal circuits in 28 out of 29 patients. And that's actually a reason to put patients on full dose anticoagulation. Similarly, patients who are on dialysis, if there's any clotting, you can use full dose anticoagulation. ECMO patients are known to clot the circuits, and again, that's somewhere where you can use blood thinners judiciously. And keep in mind that of these patients that were studied, 70% were actually on prophylactic dose anticoagulation at the time they developed the blood clots. So again, that tells you how serious this is overall. Arterial events have been reported. They are very rare. I have to say, again, we haven't seen much here in our practice, but they have been reported. We've had some reports of young strokes. There was a single health system that identified 5 cases of acute ischemic stroke associated with COVID-19 over a 2-week period, as opposed to 1 stroke they see every 2 weeks. So they obviously associated it with the occurrence of COVID-19. So again, something that is evolving, and we are still trying to understand this as we see more and more patients. I had a young patient that I saw with a stroke. He was referred to me by neurology about 2 weeks ago, and again, we think it's COVID-19 induced. He was a 45-year-old guy with no major risk factors. And then there are reports of limb ischemia also, again, rare, but it has been reported. Interestingly, with the limb ischemia data that we have, most of the patients reported are those who were older, who had a lot of comorbidities like hypertension, diabetes, peripheral vascular disease. So haven't seen it in young folks, but again, there have been reports of it all over the US. Okay, so I know we're short on time, so I'm just going to go through the evaluation and treatment. when it comes to these patients who have COVID-19 proven by test, or if the suspicion is very high, we usually do a standard battery of tests in all patients, which includes CBC, coagulation studies, fibrinogen, and D-dimer. And the frequency of D-dimer all depends on how the patients are doing. In the ICU, it's done every day. If the patient's in the ward, it can be done once every couple of days. All depends on, how the patient is doing. Again, remember, we don't make any major decision making based on D-dimer levels. It is just a prognostic marker. Initially, it is used to stratify patients, but there is no evidence to suggest that you need to change your coagulation parameters based on the D-dimer level. So it's more prognostic, but very important. And remember, in the studies done early on in China and also in the European countries, patients who did not survive are the ones who had a high D-dimer level, usually more than 6 times the upper limit of normal. So it's very prognostic in that sense. For outpatients, we routinely do not recommend any testing as such. And then, of course, imaging studies have to be performed as needed. Again, keeping in mind that we want to minimize healthcare, worker exposure to any unnecessary studies. And again, it's challenging in these patients because the ICU patients who are prone and on ventilators, obviously it's difficult to get imaging studies. So as much as you can do on the bedside is advisable, obviously. Now, coming to the management in terms of anticoagulation, there's been lots of guidelines. Again, they're evolving. The one that I'm discussing here is what we use in our practice, and I think is the most commonly used all over the US, is the recommendations by the International Society on Thrombosis and Hemostasis. There are guidelines by the American Society of Hematology, and then the ACC Cardiology has their own guidelines, but I believe these are the ones that are most widely utilized. So there are, cannot underscore enough the importance of supportive care in hospitalized patients with COVID-19. That is the number one thing, of course, whether you end up using antivirals or hydroxychloroquine or whatever the hospital protocol is, but supportive care is the single most important thing. And we always encourage institutions to continue with the standard medical, surgical, and obstetric guidelines for anticoagulation. So that should continue as it is. But more importantly, for COVID-related anticoagulation, 5 different areas have been identified and guidelines have been put in place, and I'll quickly review those. First of all, the diagnosis of VTE in hospitalized COVID patients. So initially there was a practice all over, at least in the US, where everybody with COVID-19 was getting Dopplers and D-dimers, or they were getting Dopplers based on high D-dimer levels. That has not been recommended anymore by the International Society of Thrombosis and Hemostasis. The recommendation is that the practitioners should use standard of care objective tests, like a Doppler or a CT scan, CT angio, based on just clinical suspicion. So just like we usually do it in a standard hospital setting. The second thing is VTE prophylaxis in non-ICU hospitalized COVID-19 patients. So these are people who are in the hospital and you want to prophylax them. So the universal strategy right now, remember, these are non-ICU patients, so they're not the sick ones. The routine thromboprophylaxis is what we usually use, which is low molecular weight heparin or standard dose unfractionated heparin. And intermediate dose is almost never used. I'll discuss that a little later, but pretty much for the most part, it is prophylactic dose low molecular weight heparin. 40 milligrams of Lovenox once a day would be sufficient. And then, of course, if there are certain reasons that the dose needs to be modified, for example, obesity or severe thrombocytopenia. And again, in COVID, we tend to go towards the lower end of thrombocytopenia. So we give anticoagulation as long as the platelet count is above 25,000, as opposed to 50, which I know a lot of places do otherwise. But I think as long as there's no major risk of bleeding, we go all the way to 25. So that's for standard patients on the floor. Now for VTE prophylaxis in the sick ICU patients, actually, this is the gray zone. I think all institutions are using their own protocols. I'll share the one that we use in our facility, but the consensus of the experts is that the routine thromboprophylaxis should be with prophylactic dose, unfractionated or low molecular weight heparin, just like the ward patients. However, intermediate dose low molecular weight heparin can also be considered in high-risk patients. There is still no evidence to show that treatment dose heparin should be considered for primary prevention until the results of randomized trials are available. Obviously, that's the consensus. But like I said, a lot of centers are using it with good results. This is based purely on expert opinion and experience. And of course, multimodality, thromboprophylaxis, I think should be used. If you have mechanical methods, especially in the ICU, they should be combined with chemical prophylaxis. This is, I don't know if it projects very well, I apologize, but this is the protocol that we use in our facility. We have divided patients into 2 tiers, tier 1 and tier 2. In tier 1, if the patient has a high suspicion of COVID-19, or if the patient is positive and is requiring more than 2 liters of supplemental oxygen, then we put them on enoxaparin 0.5 milligram per kilogram twice daily, which is equivalent to what we call intermediate dose, anticoagulation. And if any of the following occur, which is this long list underneath, I won't go into details, then you have to escalate to either tier 2 or you de-escalate depending on which one of these criteria is met. But anybody who falls in tier 2, which means high suspicion or positivity for COVID-19 confirmed, along with either a D-dimer that is more than 6 times the upper limit of normal, or an SIC score of 4 or greater. An SIC meaning sepsis-induced coagulopathy score, which is based on your platelets, PT, and 3 parameters. So again, our critical care folks are very aggressive. They have been using these protocols with a lot of success. I know there's not a lot of evidence behind it right now still. We are learning, but it's worked very well for us, and we feel that it's easy to take patients off the ventilator when they're on full dose anticoagulation. If especially if you're suspecting microthrombosis of the pulmonary vasculature, again, is an evolving, evolving thing. And I'm sure over the next couple of months we will come up with better guidelines so everybody can follow those. Coming to the 4th guidance is how long do we continue VTE prophylaxis for these patients? And usually we do either low molecular weight heparin or a direct oral anticoagulant like Xarelto, Rivaroxaban, or one of the others. We do it usually anywhere from 14 to 30 days. It all depends again on the patient's physical condition. If it's somebody who was in the ICU, was immobilized, was on a vent, and now is going to the floor or going home, you probably want to keep them on blood thinners for at least 14 days. So again, this is just based on practice patterns, and this is what the expert panel recommends, is to consider 14 to 30 days of anticoagulation on a case-by-case basis. If you have somebody who is doing very well clinically with no major risk factors, no cancer, no immobility, you could probably get away with no blood thinners. And then finally, VTE treatment in hospitalized patients. So we're coming to treatment from prophylaxis. And again, this is based on established guidelines, which we usually do. If you have somebody with a confirmed thrombosis, PE, DVT, you just treat them with standard blood thinners. Again, low molecular weight heparin is preferable. And really, low molecular weight heparin is superior, in my opinion, to heparin simply because it has an anti-inflammatory effect that heparin doesn't have, especially in cancer patients. We know that low molecular weight heparin is better. And then, of course, it is easier because with heparin drips running, again, there is more patient exposure to healthcare providers. So I think low molecular weight heparin, is superior in that setting. Again, as discussed before, anticoagulant regimens should not be changed based solely on D-dimer levels. And then, occasionally, if you have a patient who is getting prophylactic anticoagulation or intermediate dose, and you feel that they're difficult to keep up their oxygen, and you have a suspicion that patient may be developing pulmonary microthrombi and ARDS, it is reasonable to escalate to full dose anticoagulation, and we do that at our facility. And again, I think the results are reasonably good. Duration of treatment should be at least 3 months, like other episodes of DVT or PE, and you can go up to 6 months. So just to summarize, the indications for full dose anticoagulation in COVID patients would be either one of those 3. Number 1, documented or presumed VTE. Number 2, clotting of intravascular access devices. And number 3, what we just discussed, possible but uncertain role of therapeutic level anticoagulation for critically ill patients who are in the ICU and often ventilated. And TPA can be done in any other, just like other scenarios where you feel that the patient meets the indication for TPA, like an acute stroke or a massive, I apologize, this is massive PE, the first one it somehow missed, and then acute MI or limb-threatening DVT. So just the standard stuff, nothing new there. So in conclusion, COVID-19 is associated with a hypercoagulable state along with acute inflammatory changes and lab findings that are distinct from acute DIC. The risk of VTE is markedly increased, especially in ICU patients. It's been reported to be as high as 25 to 43% in these patients, despite prophylactic anticoagulation. Management is challenging, obviously due to the equity of the illness and the lack of high quality evidence. But again, I'm hopeful over the next few months we should have some better data available with all the trials that are accruing patients. All inpatients should receive thromboprophylaxis unless contraindicated. However, some institution protocols include more aggressive anticoagulation with either intermediate or full dose anticoagulation. And then finally, participation in clinical trials is encouraged in order to improve the understanding and the most effective treatment going forward. That would be the end of my presentation. I'll be happy to take any questions if there are any.
Thank you very much to all the speakers for their excellent talks. We've got one question come through in the Q&A session, and I'll read that one out. The question is, if a patient is positive on ongoing chemotherapy and they've had a deferral for 2 weeks, do we recommend retesting for COVID PCR before resuming chemotherapy? So the answer to that question is yes, we do. What if they keep testing positive but remain asymptomatic? That is a more difficult question to tackle. The current recommendation and what we follow is to do 2 PCRs, and they have to be negative at least 24 to 72 hours apart. As soon as they turn PCR negative on 2 readings, we can then recommence the chemotherapy. We do not have any further questions, so with that, I'll bring this webinar to a close. Thank you all.
Thank you.